So in the previous video, we were talking about the obstructive pulmonary disorders. Now we're going to talk about the restrictive pulmonary disorders. I started it in the last video, and I will continue it now. Now, the fundamental difference between the obstructive lung diseases and the restrictive lung diseases is that the obstructive lung diseases are the ones that make it hard to get air out of the lungs. That breathing in isn't so bad, but emptying the lungs is the difficulty. The restrictive, however, it's difficult to fill the lungs. They are the diseases that make inhalation difficult as opposed to exhalation. I've already gone over this table 23.1, looking at the different types, but basically they can be subcategorized into things that the lung parenchyma itself, so restrictions, hard to fill because the lungs don't allow it to fill. Hard to fill because of vascular problems, edema, that kind of thing. No place for it to fill. And diseases due to extrapulmonary restriction, like broken ribs or scoliosis, things like that. So that's the way we break them down. But they all have the same effect. The lungs can't fill fully. So there's something that's going to decrease the lung expansion. So the more we can't get into the lungs, the worse the disease is. So if you can only partially fill. And this is what that spirometer that we did in the lab in AMP was about, to characterize the difference between restrictive and obstructive. If you don't bring as much air into the lungs, you can't, then you're going to have a decreased partial pressure of CO2. And you don't know about the decreased O2, and you don't know about the CO2. It might be decreased, it might be normal, because you are exhaling. It's just you're not adequately inhaling. Okay, a big parenchymal disorder that's very common. My father has it. Is fibrotic lung disease, interstitial, and really what it is scar tissue in the interstitium. So it's an increase of collagen replacing elastic tissues in the supporting cells of the lungs, in the interstitial cells of the lungs. So this isn't in the alveoli themselves, because they really don't have a lot of connective tissue. They are primarily epithelial. This is all that supporting tissue. So you get injury to these endothelial cells, to the epithelial cells of the alveoli, and then the walls thicken, and then you get collagen laid down, basically scar tissue. Well, let's stick with this one for fibrotic. My best way to describe it is if inhaling into normal lung tissue is like inflating a balloon, then inhaling into a fibrotic lung is like inflating a baggie. It'll hold air, it just doesn't have the same properties. So diffuse interstitial lung disease is related to this. There's usually immune reactions. It happens because of various irritants. It could be infections, chronic infections, that kind of thing. But it all leads to inflammation. You get this inflammatory response. We have fluid and debris moves into the alveoli, and then you get fibrosis. So at the acute inflammation becomes chronic, and you get these fibrotic changes. And then you lose the alveolar walls. They're no longer functioning for gas exchange. So this fibrosis and diffuse interstitial lead to difficulty breathing and desaturation. They don't get enough oxygen into their blood. Rapid shallow breathing, and that's because what they're trying to do is exchange what they can as often as they can. They try and make the minute volume go up by breathing quicker. There's a lot of non-productive cough. You get some clubbing of the nail beds, some crackles. If the desaturation goes far enough, you end up with cyanosis. Weight loss, anorexia due to not enough oxygen, not enough ATP, and no exercise, because exercise exacerbates the problem. So these people don't tend to exercise. Their cardiac output can't keep up with the demands, so they can't do it. My father actually has an instrument that he can check his saturation at any given time, and adjust his oxygen supplementation accordingly. He's okay at rest. Any amount of exercise, he has to use oxygen. So I'll let you go over this table yourself, but it's age-related things that contribute to restrictive lung disease. So it's really infants and elderly, both ends of the spectrum, and it's really a self-explanatory table. Okay, so now we're going to talk about some of the things that cause lung collapse, atelectatic disorders. A big one is this acute respiratory distress syndrome, otherwise known as ARDS. Now, ARDS is a fairly broad category. It's when there's fluid builds up in the alveoli, in the lungs. The more fluid means that you can't get air to that part of the lungs, and therefore not to the bloodstream. So this deprives the body of oxygen. So the big thing about ARDS is that it usually and typically occurs in people who have significant other pathophysiological processes. It happens to seriously ill, critically ill patients, people with big injuries. It often is the cause of death in those people. They're not going to succumb directly to the other pathophysiology, but this complication. So the mortality rate is actually quite high. The mortality rate is kind of based on the severity of the other illness and the age of the person. And then even survival can often leave pretty bad consequences later. So it can happen for a bunch of reasons. And really what this is inflammation at the alveoli and the alveolar capillaries and causing a leakage of fluid into the capillary space. Sepsis is probably the most common cause. So this is a body-wide infection that is transmitted through the bloodstream. Another big one is aspiration of vomit. This is what a lot of ill people, they'll vomit and then aspirate some of it, and then the hydrochloric acid damages the alveoli. It gets right down into that, and it becomes a real strong irritant that that causes this inflammation. Fat emboli, so that happens post fracture, where the yellow marrow in the bone escapes into the bloodstream and will form non-soluble emboli of basically globs of fat, and then that will irritate the capillaries. Again, it's an emboli, so it goes through the veins, through the heart, and the place that it ends up is the lungs, because that's the next place where we have narrowing to go to capillary bed. So that's where it migrates to, and so it can cause this acute respiratory distress. And just shock will do it, like severe quick drop in blood pressure. Now there's an awful lot of different things that that can cause it. So shock is right here. So that's any process that leads to a low blood flow state. So that's could be hemorrhage, could be a lot of things. Infectious sepsis, pneumonia, tuberculosis, that all makes sense. Trauma, any embolism, so any thrombus or fat emboli, air emboli that gets to the lungs. Head injuries can really affect the breathing centers and the cardiovascular centers, and can lead to this. Aspiration of either gastric contents or water in a drowning situation. A lot of recreational or mostly recreational drugs, so heroin, methadone, barbiturates, salicylates, those kinds of drugs that will depress the respiratory and cardiovascular centers in the brainstem on an OD situation can do it. Inhaling irritants, smoke, corrosive chemicals like ammonia or chlorine gas, things like that. And those sorts of irritating things. It says freebase cocaine. I'm going to guess if you're freebasing meth too. Whatever. Radiation can do it because these tissues are very delicate, and a severe dose of radiation could do it. Different hematological factors, metabolic disorders, pancreatitis. Pancreatitis will make you throw clots. It's all kinds of things. Burns, anaphylaxis, preeclampsia, which is or eclampsia, which is pregnancy-related disorders. High altitude, so there's not enough partial pressure of oxygen can trigger this. So what you get is this pulmonary inflammation throughout the entire lungs, and so you get this leaky pulmonary capillaries, and the fluid builds up. Now, another problem here is if you don't have enough surfactant and you have all the surface tension of this liquid, it can cause an atelectasis, and this is why it's in with these disorders. So surfactant prevents surface tension, which then prevents from collapsing. You don't have enough surfactant for the amount of liquid, and you're at risk of collapsing. If you survive this, fibrosis is often a problem. So it's injury to the alveolar from just about anything. So what you get as symptoms is real shortness of breath and labored breathing, often low blood pressure, and then you're not making any ATP because of this lack of oxygen, and so you end up with confusion and extreme fatigue. And it's people just fall asleep. So you get hypoxemia. The perfusion of and ventilation coupling is very poor. So you end up with shunting around, and that's because you can't ventilate the areas that are filled with liquid. You get a decrease in lung compliance. So lung compliance is how easy it is to expand the lungs, and so this becomes harder to expand the lungs. That's why it's a restrictive thing. You lose or inactivate the surfactant. The fluid fills to impair the ventilation. The edema also makes the lungs very non-compliant. And this can lead to atelectasis, basically lung collapse. This is pulmonary edema that doesn't have to do with cardiac things. So this is not post-myocardial infarction or cor pulmonale, that kind of thing. So, like I said, respiratory distress, severe shortness of breath. Heart rate may go up, difficulty breathing, partial pressure of oxygen goes way down. As this carries on, heart rate goes way up, you try and breathe very rapid and shallowly, blood pressure drops, real difficulty in breathing, so you see them using accessory muscles. they're breathing so hard that you get retractions. You're creating a low pressure that isn't sucking air in, so it actually sucks the body wall towards the center. And cyanosis, obviously, a lack of oxygen. This is the pathogenesis of it. You can look it up in the book and follow along, but it's really how the capillary membrane injury happens, and how we compensate. And this will take you right through ARDS. Okay, so there's a similar thing that happens in infants, especially preemies. It's called IRDS, or infant respiratory distress syndrome. It's similar to ARDS, except obviously it's in infants. It used to be called hyaline membrane disease, and that's the name that I learned when I was in school, and it's the name that you will hear on the floors. It's a syndrome of preemies. It happens in almost 60% of babies born pre-30 weeks, unless they are treated with steroids, and it still happens in some that are treated with steroids. So the risk factors are being born early. Parental diabetes may be a big thing with this. So gestational diabetes can be a problem. Poor oxygen delivery around the time of birth, so asphyxia from a cord wrapped around, mothers having hemorrhaging before birth, sometimes a second twin, RH incompatibility can lead to this as well, especially if it's not treated. They used to call RH factor incompatibility blue baby syndrome, and they were blue because they were cyanotic, usually because of IRDS. So cesarean sections pre-labor. So this is scheduled C-sections, have a higher risk of this. Now, the big thing to remember is that in the womb, there's no breathing. Oxygen comes via the placenta and the umbilical cord. So there is no reason for the developing child to start making surfactant in the lungs. The lungs aren't inflated yet. The lungs are not working yet. So surfactant is one of the very last things to be made. And if the baby is born prematurely, there may not be sufficient surfactant. And so what happens then is the newborn's lungs are very difficult to fill. There's very low compliance because of the lack of surfactant. And it's more so even in infants than a lack of surfactant in adults, because the baby's thoracic cage is very soft. And so in the effort of actually trying to decrease and and inflate the lungs will actually draw the ribs in, and the chest wall becomes too compliant. So the diaphragm will contract and pull down, and instead of filling the lungs, it will actually draw the ribs and sternum in, and so there's not enough ventilation. So there's lots of surface tension and decreased compliance. Like I said, the newborn can't breathe, and when they can't, the bit that they can, there's not very much ventilation, and there's lots of work, which requires oxygen, which you're not delivering. This can lead to atelectasis. It might even be primary, where the parts of the lungs just don't inflate even for the first time. But get them inflated and they'll collapse easily. So because of ventilation perfusion coupling, if there's no ventilation, there's no perfusion, so this leads to vascular resistance on the pulmonary side, might lead to pulmonary hypertension. There's not enough oxygen being delivered, so they end up in hypoxemia and cyanosis. They also end up in an acidosis, as we learned from the last section. This low ventilation will lead to acidosis in the buildup of carbonic acid. It can be complicated by the fact that the capillary blood supply in a newborn, it can be immature in the lungs. In a preemie, it's even more so, because again, that develops very late in development. So there can be areas of atelectasis, there can be complete atelectasis. And there's inflammation, and fluid can build up as well, just like in ARDS. So what you see is this shallow respirations and retractions of the ribs and the sternum. Flaring of the nostrils happens because they're trying to breathe, and so there's a lot of work to it, and the nostrils will flare. Low blood pressure and slow heart rate. Some peripheral edema, low body temperature, oliguria. Oliguria is a lack of urine production. Rapid shallow breaths. If it goes on, they start to get a frothy sputum because of the liquid that is building up, cyanosis, right? And a paradoxical seesaw movement of the chest wall that as they're breathing in, instead of the chest wall expanding, the chest wall contracts. And so to see a chest wall contracting on inspiration is a very odd thing. Seeing the chest wall expand on expiration, so it's this paradoxical. This is why newborns are often treated with surfactant to try and prevent some of this stuff, and they're treated with corticosteroids to try and speed up the development of surfactant, but also to diminish any of the inflammatory parts of this, where the fluids are going to start to fill up with liquid and exacerbate the problem. Okay, so now let's continue with other causes of restrictive disorders. Neuromuscular disorders. This is when the respiratory muscles are not working properly and allowing proper ventilation. So it's restrictive, it prevents inhalation, it's not obstructive because exhalation is passive. This is an inhalation problem. So anything that's going to affect the muscles or the neurology, the motor neurons that supply those respiratory muscles are going to be involved with this. So we're going to start out with something that's very rare in North America, poliomyelitis. Now, it used to be very common before vaccination. This is one of the great success stories of vaccination. Smallpox and polio are two of the great success stories. So what polio is it's a virus. And the virus is spread person to person, usually fecal-oral route. But it could be contaminated food, contaminated water. In any case, it enters the GI system, multiplies in the intestine, and then it invades the nervous system. And it's in the spinal cord and brainstem, and it attacks motor neurons primarily and causes paralysis. They used to call it infantile paralysis. That was the old name. It affects kids, and so there's an awful lot of kids used to get it, not so much. In North America, the incidence of polio now is very low. It's 1.6 cases per million. So there's about 8 to 10 cases a year in North America, and they're all related to a susceptibility to the polio vaccine itself. There are virtually no cases in North America of people getting polio from the wild virus. Now, the big fear is people that are not immunized and are not immunocompetent against it. The introduction of a wild virus due to immigration is fairly high, and we'd hate to see a reintroduction of polio. So there's kind of like this whole idea of herd immunity in the vaccination right now, and that's a real good reason to maintain vaccination rates. The benefits far outweigh the risks to it. That's a whole other discussion that we could have at a later date, but nevertheless, the new cases due to unvaccinated people, wild virus and unvaccinated, are usually immigrants. And what's crazy is there's an awful lot of people that have this, and they're carrying this virus in their intestinal tract, and they're asymptomatic as far as the neural parts. So it really is, kind of a bad luck of the draw sort of thing. You're going to get fever, headache, vomiting, diarrhea, constipation, and maybe respiratory insufficiencies, especially if there's paralysis in the respiratory muscles. The normal course of the disease is paralysis starts peripherally and moves towards the center core. I sincerely doubt that anybody in their clinical practice will ever see a case of this, but it is important to know that it exists out there. Amyotrophic lateral sclerosis is Lou Gehrig's disease. And this is a disease, is a degenerative disease of both upper and lower motor neurons. As you remember from AMP, upper motor neurons are above the level of the spinal cord. The lower motor are the ones that exit the spinal cord and actually go to the target motor units. This is a degenerative disease, and it's progressive. And what happens is it de-innervates skeletal muscle, so it leads to profound weakness. Muscles waste away. There's no muscle bulk because there's no innervation. Stephen Hawking has this, and that's, picture him, and you can probably picture that muscle wasting. It happens in the motor neurons, in spinal nerves, and in cranial nerves. Oftentimes what takes these people is this profound weakness in respiratory muscles, and they basically suffocate because they can't inhale. Muscular dystrophy is it's a horrible disease. It's an X-related recessive problem. Mothers that are carriers have one X chromosome that carries this defect, and the other X chromosome that doesn't. They don't get the disease. Their daughters may be carriers or may be not carriers, but they don't develop the disease because they have two X chromosomes. Sons, however, 50% of sons will actually get the disease because they don't have another X chromosome to offset it. So it's a very sad disease from that point of view, that mothers give it to sons. 1 in 3,500 births, so that's a fairly high rate. It runs in families, obviously. What happens here in muscular dystrophy, the dystrophin protein, the protein that holds the myofibril to the sarcolemma in a muscle cell, is improperly made and weak. And in contracting the muscle, in contracting the sarcomeres in the myofibrils detach, and so the muscle cell weakens, and it puts more pressure on the remaining myofibrils, which have to contract with more force, which is more apt to rip the dystrophin off, etc., etc. And that will go until all the dystrophin of all the myofibrils in a cell have disconnected, and now that cell becomes non-contractile and useless, which then puts more pressure on other cells within the motor unit, or within the fascicle, or within that skeletal muscle, and makes it more likely for them. Now, myofibrils are constantly being made and replaced, but not once that muscle cell has 100% loss. There is no going back from that. So this is a very slowly progressive disease, and the muscles weaken and waste away. Actually, they end up with pseudo-hypertrophy because they fill with fat, but that's another story. In the muscles that we use the most. So postural muscles are the first things to go. So these young boys have difficulty with walking and standing, and it becomes a progressive thing. Then they end up in wheelchairs, and upper limbs start getting used more. So then they start to become involved. And then later, someplace around in the teens, 20s, maybe even to age 30, the respiratory muscles start to really become involved. Now, these muscles are involved right from the beginning. It's just that the rate of damage and the rate of repair keeps pace for a long time. But once the respiratory muscles become involved, you end up with a restriction, a lack of breathing. So hypoxia and hypercapnia are really big. Frequent infections because you're not able to ventilate properly. So very difficult. And a lot of these young men die of respiratory complications. Another neuromuscular disease, and it's probably more common, is Guillain-Barré syndrome, Polyneuritis. It's an acute syndrome, and it follows some infection, a viral or bacterial infection. It's an ascending paralysis, and what it comes from is an autoimmune attack on the Schwann cells. It's a demyelination of peripheral nervous system, not of central nervous system. It doesn't affect the oligodendrocytes like multiple sclerosis does. It's the Schwann cells in the peripheral nervous system. So autoimmune, it's triggered by the immune system attacking an infection, often with Campylobacter jejuni, and so there's probably some the antigen on that bacteria probably is similar to proteins involved in the Schwann cells, and that mistake happens. People recover from this usually. 3 out of 100 die, but usually there's recovery. The paralysis usually is symmetrical, starts in the lower limbs, and then comes up into the trunk. If the cases are really severe, then respiratory muscles are involved, and then that leads to breathing difficulties. In the past, this was, I don't know if you've ever heard of the iron lung. These were machines that would help people with Guillain-Barré syndrome breathe until they recovered from the disease. They didn't use iron lungs so much for polio because people didn't recover from polio. They didn't use it for Lou Gehrig's because people died. They didn't recover from Lou Gehrig's. They used it in Guillain-Barré as basically a stopgap to help them breathe until the disease could run its course. An interesting aside, an interesting note is Jonas Salk, the inventor of the polio vaccine, ended up with Guillain-Barré syndrome and on a respirator. Now, they don't use those big iron lung things anymore, but they use respirators. to help. Nowhere near as crude as in the past. Myasthenia gravis is something that I've talked about a couple of times already. It is an autoimmune attack on the receptors to acetylcholine, the neurotransmitter that's involved in the motor neurons, in the somatic motor neurons, and the synapse with muscles. So you get a decreased number of receptors, and therefore weakness in the somatic muscles. The peripheral and respiratory muscles can be affected by this. Now, what's interesting is that the more you use a muscle, the more receptors are developed, and kind of the less you use it, the less. So the less you use a muscle, the more time that muscle cell has to make new receptors to replace the ones that are being attacked. So muscles of facial expression and muscles of talking and those sorts of things fatigue usually first. The fear is that respiratory muscles will fatigue because you use them all the time. Now, this can be managed. It can be managed with drugs by inhibiting acetylcholine esterase. Drugs that inhibit that means that there's more acetylcholine stays in the synapse for longer, and so there's more of an effect. There's all kinds of other therapies, mostly centered around rest, that are useful. I'll just leave it at that. Now, respiratory failure can happen, especially if the immune system gets fired up and the illness gets more severe, or with other illnesses, or with reactions to medication, that kind of thing. Now, because these people are able to regenerate more of these receptors, this waxes and wanes. So we can have respiratory failure, and if the person is saved, then it's reversible, and you go on until the next episode. So this is a chart outlining what we've just talked about. So you can go through that as a summary. Other restrictions can be just simply the chest wall and the deformities of the chest wall. Scoliosis, especially kyphoscoliosis, where the spine has inappropriate lateral bends and inappropriate A to P bending, especially in the thorax. That kyphotic curve gets exaggerated, the scoliosis gets exaggerated, means that there's no room for the ribs to move, there's no room for lung expansion. It's actually being compressed by the deformity of the skeleton. All kinds of different reasons that you might get kyphoscoliosis. Neuromuscular ones, so muscular dystrophy, polio can happen. There's something called neurofibromatosis, which used to be called von Recklinghausen's disease. It literally, these ganglions start to push the spine over. Marfan syndrome is inappropriate growth of the of the bones and the shape of the bones. Most scoliosis are idiopathic. It usually happens at the growth spurt. 7-to-1 female to male ratio. There's a congenital problem called Pott's disease that will lead to it, but it doesn't really matter. These are skeletal things, and what it matters to the respiratory system is that it prevents the lung volumes from being full. It can increase the pressure and so therefore cause atelectasis. It restricts filling, so it can lead to hypoxemia. Dyspnea on exertion makes sense. Rapid shallow breathing because you're trying to move air. You don't have as much with each breath, so you need more breaths, right? Usually it's a problem of hypoxia because it's restrictive, it's air going in. Later, you may get a hypercapnia because you're also having trouble evacuating air. But usually it's a problem of hypoxia. Here's some pictures of, so this is a pretty severe kyphosis, there's a scoliosis, there's a little bit of both. Flail chest is basically multiple rib fractures. It used to be a much bigger problem before airbags and before collapsible steering columns, that people that got into car accidents, the driver, the steering wheel would literally cause flail chest, break all their ribs and their sternum. And cause this problem. Now, the ribs break in two places, which means then that the whole front of the chest is not connected to the spine properly, and so you can't expand, and the chest wall free floats, and you get this paradoxical thing that the same thing that we talked about with infants, that on breathing in, instead of inflating the lungs, that low pressure actually moves the ribs back. So instead of the ribs moving out on inhalation, they move in. So it's a paradoxical thing. Often the sternum is involved. So you can imagine how this alone will prevent inflation of the lungs, because the more you try and inflate the lungs, the more you pull the chest in. So it's restrictive in that case. Now, oftentimes it's pretty hard to break all your ribs and get a flail chest without also damaging the lungs. So there's contusions in the lung tissue itself. Inflammation, so you get decreased lung compliance, and often respiratory distress, respiratory failure. Lots of times there will be a hemorrhage, and you may get a hemothorax at the same time. So you get this paradoxical motion of the chest, shortness of breath and cyanosis, pain when you move it, because you can imagine these are fractured, right? Hypotension, hypoxemia, hemothorax, maybe pneumothorax, subcutaneous emphysema, which we talked about. That's the air going in the tissues. Obesity can lead to respiratory disorders. It's really excessive body fat. So so whatever is causing this obesity, could be Pickwittian syndrome, could be hormonal things, that that kind of thing. But whatever, if you have this huge excessive body fat, you'll end up with some hypoventilation and some airway obstruction. So increased abdominal size pushes up on the diaphragm and prevents the diaphragm from pulling down. So that's going to restrict the ability to inhale, especially laying down. Sleep apnea, so soft tissue deposits in the neck, so fat up in the neck can lead to upper airway obstructions at the trachea, at the larynx, and make it difficult to breathe, especially when people are lying down. So you get decreased ventilation, which leads to hypoxemia. You get sleepy during the daytime, fatigued, and you get shortness of breath. The increased or the decreased amount of oxygen leads to lots of erythropoietin, which leads to more red blood cell formation, which leads to polycythemia, which leads to issues of viscosity, increased resistance in circulation, which can then lead to cor pulmonary, right-sided ventricular failure, pulmonary hypertension, that kind of thing. So headache is a big thing. Now, impotence and enuresis, yeah, that's not so much to do with respiratory. So we can have inflammations of the lung. So a very common thing is pneumonia. You're going to see lots of pneumonia in practice. Pneumonia is inflammation due to an infectious agent. So it could be an opportunistic thing. It could be normal bacterial flora, gastric contents, that kind of thing. It can be inhalation of viruses or oftentimes molds, which is mycoplasma, yeasts, that sort of thing, fungal things. It happens a lot in chicken farmers and things because fungi grow on bird droppings. It can also come from the blood. It doesn't have to come to the lungs, because remember, you bring air to the lungs, you also bring blood to the lungs. So a blood-borne infection can take up residence in the lungs and cause pneumonia. We classify pneumonia as hospital-acquired or community-acquired. And that's interesting because it happens enough in hospital that it's that it requires its own separate thing. And that's because there's sick people in hospitals. So there tends to be a different assortment of opportunistic pathogens, and the immune systems of the patients are lower. And so things that will cause pneumonia in those immunocompromised people probably wouldn't in the public, in the community. So there's gram-positive and gram-negative, so staph and strep, Haemophilus influenza, E. coli, Proteus, those sorts of things. So it can be any bacteria, really. Viral is a big deal. Legionnaire's disease is transmitted and it lives in the cooling condensers of air conditioning units. Mycoplasma is yeast. Pneumocystis carnae is an opportunistic one that happens in immunosuppressed people. So people undergoing chemotherapy, people with AIDS, people with anti-rejection drugs are susceptible to pneumocystis carnae. So really, pneumonia happens when your defense mechanisms are compromised, when organisms that wouldn't normally multiply do, and you get an infection. And then this triggers inflammation, right? And then this inflammation causes an exudate, which then fills the alveolar spaces. Sometimes this condenses, consolidates, and is difficult to spit up, as it were. Viral pneumonia doesn't produce this exudate, however, so it's the bacterial pneumonias and the fungal and those sorts that cause that. So there's all kinds of variations in this. Every individual, depending on their the state of their immune system, their age, their nutrition, the comorbidities, all of this really is going to vary, causing major variations in symptoms. But almost universally, you get breath sounds, you get these crackles that you hear. People have fever and chills. They have purulent sputum. Now, this prodrome, this feeling of an upper respiratory happens first, usually with viral. And that's because most of the viral pneumonias are descending. They start as an upper respiratory tract infection, influenza, things like that. And then they move down. You tend to get fatigue and malaise, headache. So this table looks at the different types. So if you have Staph aureus versus E. coli virus, pneumocystis carnae. So it's worth going through that table. Okay, SARS. We had a big scare of SARS here in Ontario a few years ago, 2004. It was unknown before that. It seems to have been unknown since then. Because of what we learned with this, because it was quite virulent, there was a big learning curve on a lot of fronts, and there's a lot of protocols in a lot of hospitals still in place that are resulting of SARS and the SARS outbreak. The media learned a lot about it too, and they were reporting all the suspected cases of SARS. It got to the point where there were a lot of people that thought as soon as you got south of Highway 7, you were immediately going to die. It turns out that not that many people did die. There was only a mortality rate of about 10%, but it was 50% of people, of more elderly people. So it was an epidemic. It was virus. It was the coronavirus. It was transmitted through respiratory droplets. So you had to come in contact with it, but people coughing in their hands and opening a door you could touch, and that kind of thing. So it was those sorts of things that. So it's the reason that every time you go into a hospital now, and all over the place, there are hand sanitizers. Those things didn't exist before SARS. There's a severe respiratory form of it. It incubates in about a week. They become ill within 10 days. And it's not that higher mortality rate, but it was a very scary thing. So people got high fevers, muscle pain, headache, non-productive cough, and dyspnea because it was primarily a lung infection. Hopefully we won't see this again, this level of epidemic. Tuberculosis is a disease of Mycobacterium tuberculous. It's an aerobic bacteria. It has a very high mortality rate for people that get it. And this is pulmonary tuberculosis. You can also get tuberculosis outside of the lungs. It causes caseous necrosis. Most people are not high risk. People that have had prior infections with it are high risk. People with immunosuppression or malnourishment. People living in overcrowded conditions like prisons or just overcrowded. It happens a lot in immigrants because of vaccination issues. The elderly become more immunosuppressed, so that is makes them more at risk. Infections, so it passes through droplets, and it is this specific bacteria that does it. But there are individuals, so people that are drug users, crackheads, tend to be malnourished, immunosuppressed, and live in crowded conditions. And so it spreads through these populations a lot. It can go to other organs. It can spread via blood and infect other organs. And that'll be called disseminated. So the primary is the initial infection. You may get the infection, and your immune system takes care of it, walls it off, and no signs, no symptoms, and it can be dormant for a long time. Then it reactivates, usually because of some impairment to the immune system. So people can go just fine for a long time, and then they take a whack to the immune system and it reactivates. So the bacteria gets into the lung tissue. The macrophages ingest it, right? And then the microorganism persists. That's and it causes this caseous necrosis. Reactivates if you're immunosuppressed, and it gets out and ends up maybe spreading through the lymph. But basically the infection flares up. So you got to catch it from somebody, so you have to have contact. Low-grade fever, cough, night sweats, fatigue, weight loss. It impairs breathing. So weight loss, malaise, anorexia, all of those things go with it. You see it on x-rays. There's blood tests that can tell whether you're exposed. On physical examination, you get crackles and you get areas of consolidation. I don't know whether the malnourished is a symptom of it or a cause of it. Either way, often see these people as malnourished.